in Q&A. So I'm very excited about this event today. Our topic is how is myelofibrosis staged? And we're going to be joined by Dr. Lucia Masarova and Dr. John Mascarenhas. We'll see if Dr. Rampal is going to make it. I know that he is a little bit delayed today, so we'll have to hold off to see if he's going to be here for sure or not. But this topic was chosen because individuals living with myelofibrosis often are a little bit confused about how the staging process works. Everyone, when we're talking about cancer, that's such a common thing to talk about. What stage are you? And with a disease like myelofibrosis, that conversation is a little bit more nuanced and a little bit more tricky. So I think today's event should really offer some light to help clear that up. And we're joined by some fabulous speakers. The first topic that we're going to be addressing today is what is myelofibrosis and how is it staged? And joining us for that portion of our presentation is Dr. Lucia Masarova. Dr. Masarova is an assistant professor of the Leukemia Department at MD Anderson Cancer Institute, or Cancer Center, sorry. Her clinical and research focus is on myeloproliferative neoplasms, and she is particularly interested in developing novel therapies to address the complex needs of MPN patients. She's wonderful. I've had the chance to speak with her a couple of times, and she is incredibly nice and informative. So I'm really looking forward to hearing you speak today, Dr. Masarova, and I'm sure our audiences as well. I'll let you go ahead and take over your screen share there.
Thank you. Thank you very much. I still cannot see my video, but I can hopefully get you all hearing me.
That's Dr. Sorry, Dr. Mascarenhas, I accidentally clicked on you instead of Masarova. A lot of masses going on here. Let's see. So I have Dr. Masarova. You should be spotlighted. And you should also be co-host. So you should have access to sharing your screen. We see your face.
Let me see, how do I share it? 1 second.
On Zoom, it'll be the little green button that says share at the bottom, and then you, depending on how you have it set up. Cool.
So, can you see that?
We see that. We also see all the slides along the side. Now we see it full screen.
Okay, so this is better.
Perfect.
Perfect. Okay, so thank you very much, healthy people. Thank you, thank you everyone for inviting me and be part of this wonderful gathering about myelofibrosis. As nicely said at the beginning, it is a very rare disease, and there is not enough, ever enough education for everybody, including all of us doing this on a daily basis. So what is myelofibrosis? It is a chronic myeloproliferative neoplasms that belongs to the classic diseases alongside polycythemia vera and essential thrombocythemia, and they are all characterized by differences in blood counts as well as clinical features, ultimately showing bone marrow fibrosis, which is more typical for the myelofibrosis patients, and it could be diagnosed as a primary disease or disease evolving from previous polycythemia vera or essential thrombocythemia. They are not focus of today's talks, but belong to the same category and usually are present in more benign way. The diseases are all very rare. As you can see, the primary myelofibrosis estimated United States prevalence per 100,000 individuals is only 4 or 6 cases. So I'm going to summarize the diagnostic criteria, but this is too deep for general population. Just keep in mind that it is a combination of findings in the bone marrow, molecular level, and clinical features, because patients would usually seek the doctors for abnormalities in the blood counts. Most of them would be abnormalities in the red cells or white cells, as well as symptoms mostly related to, in this case, that goes to the diagnostic criteria, splenomegaly. There's a little complications in terms of the overt primary myelofibrosis that is here shown on the left, and something called prefibrotic myelofibrosis that we also see quite often in the clinic when patients being referred to us. That is a subcategory that has been distinguished according to WHO in 2016. And you can see highlighted the major difference between these two is the degree of the bone marrow fibrosis, which in the prefibrotic setting should not be that significant, that is in the overt primary myelofibrosis, or diseases they are evolving from previous essential thrombocythemia and polycythemia vera, where the development of the higher degree of the fibrosis, alongside at least two clinical symptoms I just mentioned previously, basically constitute the disease progression. This is something very important because essential thrombocythemia and polycythemia vera are lifelong diseases that could not evolve to myelofibrosis, which is the next stage. And then only having development of the fibrosis without other minor criteria, such as anemia, no need for phlebotomies, lack of symptoms, lack of splenomegaly, do not necessarily mean the disease has progressed. So here I would emphasize a very deep collaboration between the clinicians, the pathologists, as well as the patients to pay attention to these little changes as the disease evolves, as people live with it. So I will dip a little bit more into the molecular basis, but will not go super complicated. The disease is, as you can see in the middle of the slides, characterized by overregulation of JAK-STAT pathway, which is a major pathway in hematopoiesis as well as inflammation. The initial understanding of this is summarized on the left. It was discovered in 2005 by the mutation in the JAK2 gene that is actually shown on the left bottom, with the specific most frequent mutation in patients with myelofibrosis being the JAK2 V617F. The red box shows 60% primary myelofibrosis patients would be basically defined by this change. On the right side are two other mutations. They are considered drivers, MIPL at the top and carleticulin at the bottom. That was the last one discovered. And then in the bubble on the right, you can see that 10 up to 15% of patients with primary myelofibrosis still do not have the driver identified. So here the research must be going on. And again, here I'm going to emphasize to the previous slide that the diagnosis also requires other features as a combination of molecular, bone marrow, and clinical. So even triple negative myelofibrosis does exist, and it exists quite frequently, more frequently than MAPLE mutated. So that's something to pay attention to as well when there is a little confusion about the proper diagnosis. However, it is not that easy. This slide is more complicated, and I just put it in to realize that there are other factors that put into the disease progression and evolution, particularly seen in the middle and right part of the slides, where other genes changes that are acquired on the disease as it evolves, particularly within something called epigenetic regulators, are starting to play a role and build up more on the drivers to a little bit changing how the disease could behave, from having more blood cells, more spleen and symptoms, to less cells, but still more and more of the symptoms, because the disease kind of shifts to different presentations. That comes to this discovery that was published a couple years ago that distinguished two major clinical phenotypes, myeloproliferative and myelodepletive. Too many words to use, but however, the difference is in terms of how the disease looks in the flavor, more driver mutation that I just mentioned versus more of these epigenomics and splicings. They are seen in other diseases. They are characterized by low counts, such as anemia, such as low red cells, or thrombocytopenia, low platelets. And they tend to have worse outcomes. So these patients fare worse because not only they have a lot of proliferative features, they have spleen and symptoms. They also have kind of a low counts and more difficulties to treat them. And the knowledge of how severe or even moderate thrombocytopenia or anemia impact this outcome is summarized on these slides with the most largest population of patients on the left. Thrombocytopenia with platelets decline significantly, or anemia, red cells decline significantly. And all of them, even slight drops, is already driving worse outcome in these patients as well as disease progression. That's why we kind of started to understand that there are a little bit different heterogeneity and needs for these patients, and that's how they have to be staged and addressed. So these slides is summarizing what I already said about the different in the myelofibrosis flavors for early disease on the left side, which is mostly addressed by observation or some support, versus the overt disease or the transformed disease on the right, which comes with much more symptoms, more organomegaly or ineffective erythropoiesis, abdominal pain, progressive weight loss, and cytopenias harder to address, ultimately all leading to poor quality of life, altered and shortened life expectancy due to various outcomes, usually as a disease progression, as well as unfortunate and most dreaded complications, a leukemic transformation. I'm putting the symptom assessment tools here because this is standardly valid, efficient tool for patient-reported outcomes that been used over the all development of medications for myelofibrosis and assess the 10 more common or most common important symptoms. You can see in the bubbles on the left that patients are always being asked in the clinics how your disease is, how you're feeling, how much of the disease burden do you have, we have to address. And on the right, this is very common for patients dealing with this disease, the questionnaire MPN-10 or MPN-SAF TSS total symptom score, where patients are asked to grade their symptoms on a tell from 0 to 10 as being the worst imaginable, and then even seeing two symptoms at the level of 3 or more could significantly clinically impact the patient's lives as well as ultimate disease behavior. So this is all incorporated into prognostication or staging, as was the name or title of my topic. Why do we need this? Well, we need it to guide the treatment decisions. What are we going to do with each and every single case? Because this disease is really very heterogeneous. So it helps us to make decisions, what tool to use, how to stage patients, and what needs they need in terms of approach. So on the left part, I put the risks and the score systems that we used over the years in the different colors, with the green, a light green, showing a low-risk patient or very low-risk patient that mostly needs observation or maybe a little bit of a support, versus the angry red and the purple are the higher risk, intermediate risk patients. They need therapy decision based on the needs. Either it's control of the spleen or control of the symptoms or addressment in the cytopenias, and including the ultimate curative approach, which is allogeneic stem cell transplantation. That decision doesn't come lightly, but it's very important to be made at the beginning when we see the disease is moving this direction. So this slide's a little busy, but it is showing the staging. It's showing the original historical clinical pathologic myelofibrosis scores that started with the IPSS shown on the left, International Prognostic Scoring System, that basically puts a different weights into symptoms the disease comes with, including age, constitutional symptoms I just mentioned on the MPN-10 score, leukocytosis or increased white cells, hemoglobin lower than 10, so anemia, and increased peripheral blasts. Then the score moved to do more dynamic assessment, shown in the middle as the DIPS, which puts more point into the anemia that was stemming from the understanding that presence of anemia that comes with the disease is the most detrimental for the outcome. And then more understanding that there are features underneath in terms of the molecular and genomics led to development first the DIPSS plus on the right, where we put more weight also onto the non-score, but plus on cytogenetics, platelets, and transfusion dependency. So we create these 4 different curves with expected behavior of the disease. And on the right part of the table, at the top, you can see the expected, what is called median overall survival. So 50% of the patients faring well while they observed. Low, which is people could live without reaching the median. So they are having extremely great life expectancy. And to the high, which is somewhere in only 1 and 1.5 years, which is actually quite terrible disease that compares to more aggressive acute leukemias or other hematologic malignancies. And we incorporated the knowledge of the genomics of the disease based on the discoveries of the driver mutations I started my talk with, because it's clearly known that patients bearing the carleticulin mutation, shown on the left with the blue, particularly carleticulin type 1, shown on the right in the red, have the best outcome with a survival that is way over 25 years, even 30 years. However, the other patient with the triple negative fare the worst. So this is the one part, the best carleticulin type 1. The worst are shown at the bottom in the pink, where we have identified over the years different genes that contribute to disease progression, a group of them called high-risk molecular mutations or HMRs, but others also were coming along, such as RAS mutations, TP53, very flavored nuances, more to point that the genomics or the assessment of the disease feature is very important these days for us to better prognosticate or understand what will happen with the disease in the next decade or two. That led to the development of molecularly or genetically enhanced scores that would not include the clinical features I mentioned, but also the knowledge of the mutations and cytogenetics. So the most commonly used is the one shown on the left, called MIPS version 2, or molecularly enhanced score, which does include the clinical factors, so points for anemia, particularly the degree of the anemia and the anemia associated with different genders because they have different impact, and then the presence or absence of the most favorable calreticulin type 1 or the most unfavorable high-risk molecular mutations or very high-risk cytogenetics. Again, you can see in the green table, the expected behavior of these patients stemming from unreached to only 1.8 years. So that goes along the heterogeneity of myelofibrosis, where people can live very long, but people, once they have more advanced features and start to set splenomegaly, anemia, leukocytosis, more blasts, are having worse outcome as every single step is pointed in towards to the disease. And then there is one last score I want to just show, but that has not been implicated in drug development, but shown to be performing better for people that would have myelofibrosis evolving from essential thrombocythemia or polycythemia vera, where on the left is an age nomogram where we plug in patient's age, and on the right are again the different clinical features such as number of platelets, presence of symptoms, anemia or hemoglobin, blasts, and absence of the most favorable calreticulin type 1 mutations. And then again, you can see the risks are coming from unreached or people living with unmet medians until only 2 years. So all of these are impacting our decision. Do we need to treat a patient? What is the best therapy we choose? And how do we approach? And I'm going to just put 2 slides to finish up my talk about how do we guide these decisions, because my colleagues will talk more about the details. But to summarize the staging, it's a lower or high risk disease where the very low or intermediate one could be plugged in into the lower. And then decision making comes from, do we have any symptoms we have to address or not? They could be observation or trying different clinical trial or even JAK inhibitors or interferons. For higher risk patients, which could come as high as intermediate 1 and then intermediate to high, very high, we make these days decision based on the most important, as I said, curable transplant eligibility, but also blood counts. Are the platelets and hemoglobin higher or lower, and how does that impact the therapy decisions? Because in patients that have high risk disease, usually would have some degree of splenomegaly and for sure would have symptoms. And the prime backbone of treating these diseases are JAK inhibitors that were developed to address the symptoms and the spleen, ultimately also leading to better outcomes. So I will just summarize to emphasize that the disease is very heterogeneous. There is almost a magic to know how to diagnose this disease, requires experienced pathologists, collaboration between different teams, paying more nuances and attention to the clinical features, blood counts, molecular testing where up to 15% could not even have identified drivers, and then prognostication and staging is cornerstone on the disease burden. How many symptoms, how are they assessed using standardized validated tools, how the counts look like, where the organomegaly sets, and then other more aggressive features that the physician would pay attention to. And then I would also emphasize the attention to disease progression and needs for regular reassessment along patients' lives, because the disease does unfortunately evolve and we cannot fall short to stop or halt the progression as of now. So I will just basically finish my talk to just bring up that disease is heterogeneous and clinical presentation and recognition of the needs of patient guide our therapy decision at the moment. Thank you so very much for your attention, and I do look forward to the discussion and questions.
Oh, I'm muted. So thank you, Dr. Masarova. That was wonderful. You did a really good job of setting up the rest of our presentation. Next up, we're going to be discussing low-risk myelofibrosis. And joining us for this portion of the talk is Dr. Rajit Rampal. Dr. Rampal is an MD, PhD. He's a hematologic oncologist at the Memorial Sloan Kettering Cancer Center in New York, and he specializes in myeloproliferative neoplasms, or MPNs, and leukemias. Dr. Rampal is a dedicated and active researcher focusing on developing new and innovative approaches to treating MPNs and leukemia. He also works to develop and run novel clinical trials with molecularly targeted agents for patients with MPNs and leukemia. Thank you for joining us today, Dr. M. Paul. If you have slides, I'm happy to go ahead and let you share those.
Yeah,
If
please.
not, perfect. You should be co-host. I stopped my share, so you should be able to just hop in and share yours.
Okay, let's see. Let me know if they're visible.
We see them. We see the slide deck on the side as well. Yep, they were full screen, so you're good to go.
All right, great. Well, thank you so much, Dalton, and I'm happy to always to speak to our patient audience because I think it's just so important that we do our part in educating our patients so that we are speaking a common language, right? I think that, to me, this is one of the most important things in terms of what we can do when we meet, for example, a new patient is to make sure that somebody walks away with a more clear understanding of their disease and their options, but that all requires that we're speaking a common language. And so, my hope here is just to sort of break down some of the ways we think about things and some of the technical jargon. So we'll start with kind of building off of what Dr. Masarova was talking about in terms of how we prognosticate. And of course, she kind of laid this out, but I think repetition is not a bad thing when you're talking about technical details. So, when we think about low risk and high risk, what we're thinking about is what is the risk of the disease progressing? That's the first principle. The one point that I think is important to make, and I'll make a number of times, is that the way we think about risk is based on a couple of different models. And that is the thing you have to keep in mind, is that these are models based on amalgamation of patient data. And these are not predictive tools. They are prognostic, meaning that we can put numbers into a system and say, this is the relative risk of the disease progressing. But what we are not saying, what we cannot say, is that this is a prediction of what's going to happen. This is a really important point, because I think sometimes when we talk about risk, when we give a patient their risk score, the patients worry about this means that this is X is going to happen. But the reality is we are far from the point where we can actually say this is what is going to happen. So everything is about a relative risk. Nothing is absolute. The second thing is that the risk scoring system is part of how we think about a patient in whole, but it doesn't dictate anything. The risk scoring system does not tell us how to treat a patient. This is an important point as well. The risk scoring systems do tell us who do we think are the patients who are at the higher risk of their disease progressing, and therefore should we think about a transplant in those patients. To me, that's the real use of the scoring system, but it does not say to me we should treat the patient with X, Y, or Z. So the scoring system has to be taken into context with what we see clinically, as well as other factors, but none of these things dictate how we actually, pursue treatment. So the most basic of the scoring systems that we have is called the IPSS, or International Prognostic Scoring System, which is meant to be used when somebody is initially diagnosed. And it takes into account a couple of factors, which is an age over 65, the presence of symptoms, a hemoglobin of less than 10, a white count of more than 25, and the presence of more than 1% blasts. Each of these things gets a point. And based on the number of points we end up with, we can put people into low or intermediate 1 or intermediate 2 or high risk. This just depends on the number of points that somebody has. Can somebody have a score of essentially 0? The answer is yes. Somebody who's newly diagnosed and on the younger side of things could absolutely have a risk score of 0. But if you look at the survival curves, right, what they say to us is that if in the most simplistic way of thinking about this, if we look at somebody who's in low risk and look at their survival, 50% of patients in the low risk group will be alive 144 months out, whereas 50% are alive at, let's say, 30 months or so from diagnosis, right? So that is how this is part of how we use these tools. There's nuance here, right? One of the pieces of nuance to me is the constitutional symptoms. It's really hard to define sometimes whether or not we really would say someone is having symptoms from their disease. If somebody is having drenching night sweats and they've lost weight and they feel terrible, this is an obvious thing. If somebody says, I'm somewhat fatigued, right? Fatigue is an individual thing, right? Everybody has different thresholds for what they describe as fatigue. Everybody has a different way to actually describe fatigue, right? Not everybody describes symptoms the same way. And so in somebody who says, I'm more fatigued than I used to be, is that a symptom? Is that a constitutional symptom, or is that just life, or is that some other medical problem? That's where things get a little bit tricky when we do our scoring. So this is not necessarily a black and white thing, and I think it's important to remember that. As the disease goes on, we have what's called the dynamic international prognostic scoring system, which essentially is the same. It takes into account the same variables: age, the white count, the hemoglobin, the blasts in the blood, and the presence of symptoms, but it puts more weight on hemoglobin. So in this scoring system, if somebody is anemic, they get 2 points instead of 1. That is, I think, an important thing, because we do have data to tell us that patients who are anemic tend to have a more progressive course, particularly those who are requiring red blood cells. And so this is an important thing. It's weighted a little bit differently, but the variables here are very much the same. There's another take on this called the Dynamic International Prognostic Scoring System Plus, which incorporates other information as well. And I don't think it's important to get into the details, but to suffice it to say, what you've heard up until now is there's a number of different ways to score risk. And to make it slightly more complicated, we now have a molecular scoring system, and you heard Dr. Masarova talk about this a little bit, in that we know that mutations definitely have an influence on how the disease progresses. And so things like having a calreticulin mutation, which you heard the implications of that, or having one of the high molecular risk mutations, this can play into the risk of progression. And so, in this scoring system, you have exactly the same clinical variables as the other ones, but now it takes into account the genetics. I think this has been an important advance in how we think about risk stratification for patients, but I also think it's something that is going to evolve very quickly and soon, because when this came out, when the genetics that are described as high risk genetics came out, this was about a decade ago, and our sequencing technologies are so much better these days than they were a decade ago. We know other mutations occur. We know that many of these other mutations actually are do impart a prognosis for patients with myelofibrosis. So this is going to change, I think, is what I would say. And with all of these scoring systems, refinement is important. I sometimes think about the scoring systems like iPhones. Every year there's a new update, new version. But that's still, it's important that the scoring systems evolve as the science evolves. So looking at everything, right, in the scoring system we've talked about DIPS, DIPS Plus, MIPS, there's a MIPS version 2. Again, there is a core set of things that many of these scoring systems take into account. And that should give us a sense that these are important and valid. There are other things that can be taken into account with other scoring systems. So, thinking about this from the patient perspective, Is there a best or right scoring system that your physician should be using in your case? The answer to me is no, because there isn't one of these that is shown to be the best necessarily. They all give us the fundamental information of, do we think somebody's got a high risk of progression or a low risk progression? They look at things a little bit differently because they have different inputs, different information. Sometimes it just depends on what information, is available. And that will dictate which of these you use. But I think it's important to emphasize that nobody should think that any one of these scoring systems is the quote unquote right scoring system. It just depends on what information you have. That being said, there is not necessarily a complete concordance between scoring systems. This is a paper that's actually from this year that actually looked at the different scoring systems, and this was done in a population in Southeast Asia, and asked, whether how much concordance is there between these different scoring systems. And this is using something called the Cohen's coefficient, and the higher it is, the more concordance there is. So the one important point is that, for example, the IPSS scoring system and the DIPSS scoring system have a pretty moderate concordance score. So that's, a good thing. That tells us those two scores are probably reflecting the same things, but that's not necessarily true of some of the other scoring systems. And the molecular scoring system was not incorporated into this particular analysis. So all of this is to say none of these things are should be thought of as a central dogma, and they should not dictate our care. They're a piece of the puzzle. Okay, that to me is one way that we have to think about this. It's also important to remember that the scoring systems don't reflect everything that we know. One of the things that, all the clinical trials we do look at for myelofibrosis is they look at, does the spleen shrink? Does the spleen get better? But if you notice, in the variables that get incorporated into the scoring system, the spleen size is not one of these, right? And we do know that with treatments, having a reduction in the spleen volume does actually correlate with doing better overall, or patients' overall survival. But this is not something that's even accounted for in our scoring systems, right? So these are far from perfect tools. And again, my point here is that the scoring systems need to be a piece of the overall puzzle about how we think about a patient. They don't tell us what exactly to do for the patient. And that brings me to the next point, which is that how we treat the myelofibrosis, regardless of the scoring system, really depends on what the clinical issue is, not on what the score is. Score, again, does help us decide about transplant, but we have to treat what we're faced with. And, there are patients who just have anemia and they don't have a huge spleen. They don't have much in the way of symptoms. We would treat those patients potentially a different way with some of the older drugs we have in our arsenal. And I won't get into specifics here. But, for patients who have an enlarged spleen or have constitutional symptoms, the JAK inhibitors, as Dr. Masarova mentioned, are a backbone of therapy. And there is data actually that I'll talk about in a moment with regard to using JAK inhibitors in lower risk patients versus, using them in higher risk patients. There are a variety of other, things that we face in patients, including patients who have more progression of their disease towards a leukemia, or patients who develop what's called extramedullary hematopoiesis, which just means that there is blood generating tissue that is growing elsewhere in the body. It can happen anywhere. It can happen in the lungs and the bones and the spleen. That's part of why the spleen enlarges. So the treatment needs to be based on what the actual clinical problem is. Now, I mentioned JAK inhibitors because patients with low-risk disease can have an enlarged spleen. And is there data to tell us that JAK inhibitors are going to benefit patients with lower-risk disease? The answer is yes. There have been studies to look at this. And here you see a breakdown of the use of ruxolitinib in patients with intermediate 1 risk disease, and here with intermediate and high-risk disease. And the major point here is that you see similar things in terms of improvement in symptoms and in shrinkage of the spleen in patients with lower risk disease, as well as with higher risk disease. But interestingly, in patients with lower risk disease, they may actually have less toxicities and side effects from the JAK inhibitors because their blood counts may be a bit higher than patients with a little bit more advanced disease. So either way, JAK inhibitors, in this case, ruxolitinib in particular, certainly can be used in lower risk disease. There's also evidence and data for interferon. Now, many of you have heard about interferon, and interferon has had a place for decades in MPNs in general, has been used quite a bit in polycythemia and essential thrombocythemia, but there has been data in myelofibrosis. And there have been a couple of studies that are essentially mostly retrospective in nature, showing that for example, if you look at responses, that patients with low and intermediate risk disease can have responses to interferon, and making this a little bit more granular, that patients with early myelofibrosis can have improvements in their symptoms, in their spleen, if they're having anemia, improvements in anemia. So there is potentially a role for interferon in early myelofibrosis. Sometimes, the conversation becomes in somebody who is not having much in the way of symptoms or spleen, is it worth thinking about using interferon early on in the disease to try to stave off the disease progressing? I think it's an interesting idea. And again, there is data here to support the idea that interferon can be useful in myelofibrosis. But the problem is that we don't have any randomized data. We don't have any data to say if you took a group of patients with low risk or early myelofibrosis and you said half of them get interferon, the other half we just observe, do we see a delay in the disease progression or the disease severity? We just don't know this right now. And that is something that is going to be a subject of discussion. So interferon is not an unreasonable thing to think about in early MF, but do we really know that it changes the course of the disease? This to me is an unknown. So at the end of the day, I will leave you with sort of my key takeaways when we think about lower risk MF. As I said, the prognostic scoring systems don't give us guidance on how to treat the patient. They do give us guidance on whether or not we should prioritize a patient to be referred to a stem cell transplant specialist. We have to focus on treating what the underlying problem is that the patient has, right? And whether that is a symptom issue, a spleen issue, or an anemia issue, that really needs to be how we decide how to treat somebody. And that there is data for various medications, particularly ruxolitinib and interferons, in patients with lower risk disease. So I'll end my presentation there, and looking forward to the Q&A.
Great. That was super interesting. And I love that you touched on interferon because that's a question that we get all the time. And I feel like it's one that I don't often hear widely discussed for the myelofibrosis patients. Obviously, it's bigger in PV and ET, but I have lots of patients that ask about it. So I love that you touched on that. All right. And then this brings us to our third presentation of the day. This is going to be covering high-risk myelofibrosis. And joining us for this presentation is Dr. John Mascarenhas. Dr. Mascarenhas is a professor of medicine at the Icahn School of Medicine at Mount Sinai. Dr. Mascarenhas is also the director of the Center of Excellence for Blood Cancers and Myeloid Disorders, directs the Adult Leukemia Program, and is a member of the Tisch Cancer Institute. His clinical and research focus centers around myeloproliferative neoplasms and acute myeloid leukemias. And throughout his career, he has published over 275 papers, been the principal investigator for the National Cancer Institute-sponsored Myeloproliferative Disease Research Consortium, been principal investigator for many study sections and numerous clinical trials, and has a very long list of MPN-related accolades. So I'm thrilled to have the chance to work with you again, Dr. Mascarenhas, and I'll go ahead and stop screen sharing so that you can take over.
All right, Dalton, thank you for the introduction. Thank you, HealthTree, for inviting me to talk on this topic today. And of course, it is always a pleasure to join Drs. Rampal and Masarova to engage patients. I've only shared my screen a billion times. Let me make sure I'm doing this right. There we go. Hopefully you can see my slides. I'll start from the top. So I'm going to address and try to complement what's been discussed by Dr. Masarova and then Dr. Rampal in building the picture of how we are staging / risk stratifying patients, and then what do we do with that information. So the topic I was assigned that I'm going to try to explore with the group and try to distill it so that it's meaningful to a group of patients is what do we do with high-risk patients with myelofibrosis based on what we've just learned about risk stratification and treatment goals, and what does that look like in 2025? And of course, I show this slide because this is a common slide that we all show at meetings, just to impress upon the patient audience that we have a lot of relationships, both from funding perspective, but also relationships with pharmaceutical companies and biotech companies that help us move things along. And that's not a bad thing. I would look at that as a good thing in this setting. Um, as we kind of highlighted, we spent a lot of time risk stratifying patients, but at the end of the day, really, what are the clinical hallmarks of the disease and how do they serve as targets? Big spleen, splenomegaly, that's a very significant hallmark. And as Rajiv pointed out, it doesn't always factor into risk stratification, but it's often a treatment goal. And I'm going to show you some data as to why we think that's important. Symptoms, this is a very symptomatic disease. It's an inflammatory disease. And because of that, a lot of different symptoms can plague patients, and they're not always the same. It could be different symptoms, and we meet patients sometimes that are asymptomatic, at least initially. But symptoms are a very big component. And then fibrosis. It is myelofibrosis, and within that bone marrow, there is a distorted architecture, and blood cell development is normal blood cell development is disturbed, and those cells end up going into the blood and into other organs, causing splenomegaly, but also causing cytopenias, low blood counts, anemia, thrombocytopenia, low hemoglobin, low platelet count. Those are cytopenias. So we're often trying to treat various aspects. In some patients, it could be all of these. In other patients, it might just be one of these, a big spleen that's bothering them, or symptoms that are keeping them from enjoying a good quality of life. So we keep that in mind when we think about what we're trying to achieve with our patients with myelofibrosis. Every oncologist is aware of the NCCN guidelines because every cancer diagnosis has a page that is set for helping guide physicians in a uniform manner throughout the country in the treatment approach for that specific malignancy. And myelofibrosis, like the rest, also has guidelines that we use, and these guidelines are set forth by many of our colleagues that get together in consensus format, develop an evidence-based and data-driven format for physicians in the community to use. And if you'll recognize this is higher risk. So these are patients with high risk myelofibrosis. The treatment algorithm is bifurcated by platelet count. That turns out to be very important because low platelets will often make it challenging to deliver effective therapy. So less than 50,000 is sort of by label, the platelet count that we're interested in, and drugs like pacritinib or momelotinib, which I'll go into, JAK inhibitors, and greater than 50,000, ruxolitinib or fedratinib, or even momelotinib and pacritinib can be options. And then, of course, transplant. And as Dr. Rampal pointed out, transplant is the only modality that we have, and this is someone else's stem cells that are infused into the patient with myelofibrosis, that offers the potential to cure the disease. Everything else I'm talking about today is really trying to address aspects or hallmarks, whether it's big spleen, symptoms, anemia, maybe improve survival, but none of the drugs or the JAK inhibitors we're going to discuss today are curative, and they don't cure the disease, unfortunately. The three of us work on a lot of different trials to try to advance the field, to look at combinations or alternative drugs that may not be JAK inhibitors, that with the idea that we could improve upon what we're providing for patients, improve the survival, dare I say, even cure patients at some point with the therapies we have. But in reality, what I'm going to concentrate today is not the clinical trials, it's not the future, it's the today. What do we have to offer our patients today in terms of drugs that address aspects of the disease that are important, and in doing so, do we improve survival? So with that, that sets the stage for the 4 drugs that are approved for myelofibrosis, and I've listed them in order of the time in which they've been approved. And I don't expect the group to look at this and have any real sense or appreciation, or frankly care what JAKs are, or ACVR1 or IRAK1 or FLT3. And the goal today is not to overwhelm the audience with a lot of molecular biology or nuances of drug development, but to point out that not all of these JAK inhibitors are the same. So there are nuances and differences based on what's called the kinome profile, or how these drugs inhibit different enzymes that are important to the biology of myelofibrosis that make them distinct, although there's overlapping. They're all JAK2 inhibitors. Nuances and differences in these drugs allow us to use them in a tailored, personalized fashion and even sequentially use these drugs. The first drug I'm going to talk about is ruxolitinib, known as Jakafi, which was approved in 2011 for myelofibrosis. It's an equipotent JAK1, JAK2 inhibitor. In the COMFORT studies, which were the pivotal studies that led to the development of this drug and then actually set the tone for all the other drugs that are in development and have been developed, it was very clear that when you randomize patients to Jakafi versus either placebo or best available therapy, you got significant spleen reduction and symptom improvement, and it was quite impactful for patients. And being involved in those studies early on, I will say it was really rewarding as a physician to see how you could dramatically and rapidly improve patients' quality of life and their functionality with a drug, an oral drug. Even if we weren't curing them, we were clearly benefiting the patient, and that was a big step forward, because prior to the JAK inhibitors, we truly didn't have rational and effective therapies. So a lot of studies have gone on to try to understand, well, what is Jakafi really doing? And are we helping our patients even beyond the obvious things? And here what I'm trying to show you is a very common theme. You're going to see this in a lot of the presentations. And what you'll notice from my presentation is, just like the two previous presentations, I'm just showing you what we show each other. And then I'm going to try to make it, more palatable and simple just by highlighting what I think is important for a patient to take away. And what I think is important here is when you look, and hopefully you can see my pointer, when you look at the left-hand corner here, you'll see week 24, week 48. These are 6 months and 12 months periods. These are the early time points we look for response. And you can see that there is significant response when looking at what's called SVR35, or spleen volume response 35. This is the amount of spleen that reduces in that period of time from baseline if you measure it with a CAT scan or an MRI. So we're significantly reducing spleen when you look at the Jakafi treated patients compared to patients who get the control arm. And then if you look at symptoms down below, similarly, dramatically improving symptoms in almost half the patients compared to very few patients who get placebo or get a non-JAK inhibitor option. So it was very abundantly clear we benefit patients, we reduce their spleen, we improve their symptoms. But what was, I think, more fascinating and caused a lot of further investigation and evaluation and discussion was it looked like we were improving survivals of patients with myelofibrosis when treated with Jakafi. And this blue line, the dark blue line up here, so the higher the curve, the better the survival, tells us that patients who moved on to Jakafi earlier in their disease course rather than waiting appeared to have the best survival. And if I just contrast that with patients down below, these are patients who delayed getting the ultimately the study drug, which was Jakafi. They had the worst survival. So it taught us a lesson that we don't want to wait to treat patients that have advanced disease to some magical threshold. We want to introduce these drugs because they do improve not just spleen and symptom, but they improve the outlook. We may not be curing patients, but we're definitely improving the functionality, the quality of life, and that translates to an improved survival, even with Jakafi. What we don't do with Jakafi is improve blood counts, and that was quite obvious from the studies that we did. I'm showing you what's called a toxicity table for hematologic or blood toxicities with the drug. So we do get some grade 3, 4 means significant. We get some significant amounts of low platelets, low hemoglobin, low neutrophil counts with Jakafi. It doesn't correct those counts per se. So we accept that because its on-target mechanism is going to reduce the production of blood cells. So that's understood. I show this slide just to make the point that we are not giving you Jakafi to improve your blood counts. But then I show this slide to make the point to the patients that even if your blood counts go low, despite the fact that both Dr. Masarova and Dr. Rampal pointed out correctly so that low hemoglobin is an adverse prognostic factor. It negatively influences outcome. What is reassuring is with Jakafi, if you have anemia, for example, with Jakafi, it does not really significantly compromise your outcome. If you're responding to the drug from a spleen and symptom perspective and you get treatment emergent anemia, it doesn't negate the benefit. It doesn't reduce your outcome in terms of spleen response or symptom response on the right. But that's also been shown with survival. You don't compromise survival in that respect. So Jakafi is still a very good drug, even if it's not a perfect drug and doesn't improve blood counts. Dr. Rampal made a really good point, which is spleen matters, even though it doesn't factor into the risk stratification. We know that if a spleen is big and we reduce it, we're going to improve the patient's outcome. And this slide I showed to make a point that you really are compromising this principle if you end up on doses of Jakafi that are less than at least 10 milligrams twice daily. And that becomes really important. Dose matters. The higher the dose of Jakafi, the better the spleen reduction. The higher the dose of Jakafi, the better the spleen reduction. And that matters because a number of different studies have shown, and I'm showing just one now, that the deeper the spleen response, if you can get a spleen smaller and dose matters, the better the survival. So I never thought that really meant that patients with smaller spleens are just going to live better. I just think it means it's a marker for optimizing JAK inhibition, optimizing the mechanism of action of this drug in patients with myelofibrosis. So you want to be able to hopefully titrate up to the highest dose of Jakafi that you can tolerate. And sometimes that's because of the cytopenias that might limit it. And that translates to an improved overall survival. So dose matters, and spleen reduction is related to dose, and reduction in spleen can correlate with improved outcomes. Let's move on to fedratinib and Rebic. This was the second drug approved in 2019. The difference here, it really doesn't hit the JAK1 as much. It's more specific and very potent for JAK2. It's also on the right a FLT3 inhibitor. Why does that matter? We know that drugs that are FLT3 inhibitors, although rational and are used in related diseases, can be associated with more GI toxicity. So we expect some of this from the kinome profile. The Jakarta study is the study I just want to highlight here. This was an upfront study done many years ago by Sanofi Aventis. And what it showed us with this selective JAK2 inhibitor was that there was really great spleen reduction here. 36 and 40% of patients at 2 different dose levels had that endpoint, that spleen response, versus only 1% with placebo. This was in JAK inhibitor naive patients. And that even if you looked at patients with a little bit lower platelets and higher platelets, that response was the same. You really got good response no matter which type of patient you were looking at. You'll see a lot of these waterfall plots, as we call them. Down means reduction. So each column is a person. 35% is an arbitrary line, we say, is in a response. But this gives you a sense of each patient had a reduction in their spleen volume with this drug, as opposed to placebo, where you see these upward columns in orange, indicating that patients during that 24-week period had a growth and expansion of their spleen, because that is the natural tendency of this progressive disease. So the blue line's going down, good sign, reducing spleens. Orange line's going up. It's the natural course of the disease if one is not having active treatment. Toxicity, as I pointed out, a FLT3 inhibitor, so we saw more of this GI toxicity. We see more GI toxicity with this drug than we do with Jakafi. In Rebic, FLT3 inhibitor, we expect to see more GI toxicity, but it is manageable. With anti-nausea medications and anti-diarrheal medications, it's usually in the first 2 months in about half the patients. It rarely leads to discontinuation if it's managed appropriately. You'll also notice that I highlighted the anemia and thrombocytopenia like Jakafi. It can also induce low blood count. So we treat patients through that and we support them through that period. You'll notice this black box on the right. Black box warning is provided to drugs when there is a concern that is beyond an expectation of what a drug may do. And Wernicke's encephalopathy is the only black box warning we have for any of these drugs. And Wernicke's encephalopathy is something that is driven by thiamine or vitamin B1 deficiency, and is a very rare finding and very easy to deal with if one has Wernicke's. And this is a constellation of being off balance, not being totally with it mentally, and having visual issues. But very easy to correct with thiamine deficiency. And I've personally never seen this with this drug. And when you use this drug, you follow vitamin B1 levels anyway, but appears a lot scarier in a black box than it truly is in person. The Freedom 2, I show this to the group just to impress upon you a nuance that I tried to point out before, which is um, we're able to sequentially and serially use JAK inhibitors in this field because they're not all the same. Here's a great example. Fedratinib was used in the post-Jakafi population of patients who had relapsed or refractory from the disease, and you can see at the approved dose of 400 milligrams in blue, all these lines going down show very significant spleen reduction versus the BAT, which also included BAT means best available therapy, which also included a significant proportion of patients who simply got Jakafi again. So this taught us that you can give Inrebic even in patients who saw Jakafi previously and still enjoy spleen reduction, despite the fact that the drug comes from the same class. Vonjo, third drug approved in 2022, April 2022 specifically, and this is a very selective JAK2 inhibitor. This also inhibits an enzyme called ACVR1 and another enzyme called IRAK1 and FLT3. So we already can see this is going to be different than Jakafi and fedratinib. And that's why this drug was developed in low platelets. We saw very early on in the development that patients with platelet counts less than 100,000, which are not the greatest candidates, particularly less than 50,000 for Jakafi and Rebic, that you could give the full dose of this drug, Vonjo or pacritinib, at 200 milligrams twice daily and still have success. And that's what I'm showing you here. So the spleen responses, 22% versus 3%. The orange is best available therapy. And the symptom responses, 32% versus 14%. And then if you specifically look at this PERSIST-2 trial data, this was the pivotal study that led to the approval of the drug, even in patients with super low platelets, less than 50,000, you could see the benefit was significant and outweighed the BAT arm, both from a spleen and symptom perspective. So for the first time, we had a JAK inhibitor that we can give to patients with low platelets with confidence to improve spleen and symptoms. So it really expanded our ability to treat the spectrum of patients with this disease. And then we started going back and looking at questions that are always interesting in the field that pertain to spleen reduction, and I showed you the Jakafi data. Here I'm showing you data that was really provocative. Even if you had a 10% reduction in your spleen with Vonjo, and that's in blue, compared to patients who didn't have that response, and the majority did have that response, what you see is an improvement in survival. Even that threshold there, 10%. Again, linking reduction in spleen with survival, and in this case, with low platelets with the drug Vonjo, that wasn't seen in the best available therapy arm, which included Jakafi, suggesting that there's something perhaps different about these low platelets. And Dr. Masarova pointed out that about the spectrum of patients, cytopenic to myeloproliferative, and these cytopenic or myelodepletive patients, their biology may be slightly different, may be more amenable to Vonjo. So that's why the drug is approved in patients with low platelets. Toxicity, well, it's a FLT3 inhibitor, like I mentioned. So it's like in Rebic, you can get some GI toxicity in half the patients. It's usually in the first 2 months. It is very easy to manage as long as a patient is aware that could happen and we give them the appropriate medications to reduce that complication if it ensues. The only thing I'll mention to patients is there's probably a doubling of bleeding risk that was independent of the platelet count. It was usually in patients who had had bleeding events previously, like nose bleeding or rectal bleeding. And again, you have to be thoughtful. One thing about myelofibrosis doctors, beyond the fact that we're thoughtful, we're also internists really at heart. So we really have to understand a lot of different aspects beyond just the hematology to make sure that we're applying the appropriate therapies and considering the risk that might be associated with them, including bleeding. So patients who are on anticoagulants, who have low platelets, that have bled previously, this may not be a smart option for those patients. So we have to consider a lot of different patient profile aspects. Anemia, I'm going to talk about anemia in 2 seconds, but anemia is really a real problem. It's very frequent. It worsens with the disease. It's part of the prognostication tooling. And we're always looking to try to improve anemia and get patients with better hemoglobins and out of the transfusion suite. What we saw with this drug, Vonjo, almost 40% of patients converted from transfusion dependent to independent. And on the right, the graph simply makes the point that there wasn't one specific patient profile. No matter how you look at the patients, they seem to enjoy better anemia responses with Vonjo than with the best available therapy arm, including Jakafi. So Finally, we're seeing some data where there's an anemia response with the drug that we give. And that leads me lastly to momelotinib, or Ojara, approved in October of 2023. And it looks a lot like Jakafi. It's an equipotent JAK1, JAK2 inhibitor, but it also hits ACVR1 like pacritinib does, like Vonjo. So you could already anticipate I'm going to talk about anemia with momelotinib. And that's where the MOMENTUM study came in. This was one of the more recent phase 3 pivotal studies that led to the approval of Ojara, taking patients who had been on Jakafi, who had some symptom burden that was still unmet, and had anemia, hemoglobin less than 10. They got the study drug, which was the Ojara, versus danazol, a synthetic male androgen used for years with a response rate of about 20 to 30% in terms of anemia, not necessarily spleen or symptoms, but an anemia drug nevertheless. And what we saw in top line results, which I'm summarizing here, was that there was better symptom control. That was the primary endpoint. 25% versus 9% of the patients had symptom response. And although this was set up in a very interesting way, it was non-inferior, meaning that it met its endpoint. 30% versus 20% were transfusion independent at week 24. So less patients were needing transfusions at week 24 with momelotinib, which is Ojara, versus danazol, which is historically an anemia boosting drug. And we saw improvements in spleen, further improvements in symptoms. So this drug really looked very nice for addressing patients, particularly who had anemia with Jakafi. And I just want to show you this graph on the right, just to give you a sense of how quickly that hemoglobin was coming up in patients. Even within the first 4 weeks, we saw this improvement in hemoglobin. Some of it may have been coming off Jakafi, but some of it was momelotinib or Ojara. And those patients did stay up. It was durable during that study period, even for patients who crossed over from danazol to Ojara, finally met together because their hemoglobins were improving, because we did see that with Ojara. Just one slide really on how we treat anemia. This is a slide I stole from the NCCN guidelines. When you have anemia, you have to understand the consequence, or the situation in which the patient is experiencing the anemia. If the patient has anemia and is on a JAK inhibitor and has spleen and or symptom burden that's well controlled, meaning that of the 3 pegs, the spleen and the symptoms are good, but the anemia is not well controlled, then we tend to, and the guidelines would endorse adding a drug to the Jakafi, for example, like luspatercept, which is an investigational drug, but sometimes can be obtained off prior authorization, off label. And that's a injection every 3 weeks that helps mature red cells. I think that will likely be available on label within the course of a year once the independent study reads out. But also ESAs. If luspatercept is an EMA, a maturation agent, ESAs are stimulating agents. They stimulate red blood cell production. These are drugs like Procrit, Aranesp, Retacrit, and then of course danazol, which I spoke about, which is oral. So there are drugs that your physicians have at their disposal. They're not great, I will admit. Procrit, Aranesp, danazol, that 20 to 30% of patients will respond, but often the responses are not durable, and we can do better than what we have. But these are some of the agents that we use to add to Jakafi. If you have someone on Jakafi who's not enjoying spleen or symptom benefit and is anemic, that's a good reason to switch them to another JAK inhibitor. And drugs like Ojara, and particularly if their platelets are low, Vonjo, those give you that option. So these guidelines help physicians in the community tailor the treatment more specifically for their patient. I have 2 slides to talk about luspatercept, because I do think that's worth talking about. This isn't a drug that's always widely available. It is approved in a cousin of myelofibrosis, myelodysplastic syndrome, and this is a drug that's given every 3 weeks, and it inhibits a pathway that's important that negatively regulates, meaning it suppresses red cell production through maturation. And when given in a study, particularly in cohort 3B, which is here, these are patients who are receiving Jakafi and have red cell transfusion needs, that you can see that 32% of the patients, I even drew the arrow to bring your attention to it, 32% of the patients became transfusion independent for 12 weeks. They didn't need transfusions. And at least half the patients had a 50% reduction in their transfusion burden. So it was quite clear that a really well-tolerated drug, I might add, was able to benefit patients while on Jakafi. They could still maintain their spleen and symptom benefit and have some benefit with anemia. I think to just get to the punchline here, the summaries. Goals of treatment for high-risk MF, we want to reduce spleen, we want to improve symptoms, improve performance status, quality of life. In some patients, improve anemia. We think that this likely improves survival, but this is one of the endpoints that we believe is important, and we know patients think are important. We have 4 JAK inhibitors that are approved that allow you to personalize the selection sequencing, whether it's Jakafi, ruxolitinib, Inrebic, fedratinib, Bonjo, pacritinib, or Ojara, momelotinib. And then we have agents that we can play with either with the JAK inhibitors or sometimes without, like Procrit, Aranesp, danazoles. Something I didn't talk about, immunomodulatory drugs like thalidomide and lenalidomide, or even pomalidomide, and then luspatercept or Reblozyl. And the future, I think, still is bright. The 3 of us are heavily invested in providing better options in the future. So combination therapies are prime time right now. Can we get rational drugs and add them to Jakafi, as well as alternative non-JAK inhibitor therapies like MDM2 inhibitors like navtemadlin, telomerase inhibitors like imetelstat, and XPO1 inhibitors like selinexor, just to name a few. Nuvisertib, a PIM1 kinase inhibitor. There's a lot of interesting and exciting research that goes from the lab to the clinic, back to the lab to refine the approach that we do believe will ultimately help patients, including a whole slew of new JAK2 inhibitors that might be prime time. And I should have put in CAL, for those CALR mutant patients listening, we have CALR-directed therapies that really look promising too. So it is a bright future. I always believe it. I really appreciate HealthTree for inviting me and assembling this fantastic trio of speakers and the patients for attending. So thank you, and I'm going to stop sharing and hand it back over to Dalton.
That was fantastic. And first and foremost, thank you to all 3 of our speakers for wonderful presentations. All of those were really informative. I am pretty tied in with the myelofibrosis space. I host multiple webinars monthly, and I'm always amazed at the amount that I learn on every one. So really, thank you all for your time. We are now in the Q&A session of our presentation. So this is your opportunity to ask questions to these experts. I do ask that you try not to get too specific, because I will try to make things a little bit more broad. But with that being said, I know that we have one question in already, so I am going to try to make this a little bit more broad. But this question comes from Sal. So Sal is 60 years old, stage 2 or secondary myelofibrosis, and has responded really well to, looks like they're on ruxolitinib plus a BET inhibitor. Had really great spleen volume reduction, but their doctors are looking at trying to do a stem cell transplant. And just where do you think stem cell transplants fit into this whole treatment landscape? If someone's responding well to their current therapies, do you think that stem cell transplant could be a good option? Should stem cell transplants be kind of reserved for just ultra high risk individuals, or is it almost better to look at stem cell transplant in people that are generally doing well because they might be able to tolerate it better? Just thoughts on how best to approach that sort of situation. And I'm going to go ahead and open that up to all 3 of our speakers. I'd love to hear what any of you have to say, because I think that this is a question that resonates a lot with many people listening here today.
Maybe I'll take the first stab, and then Rajit and Lucia can agree or disagree with me. But I think every patient who is seen by a hematologist should be considered for transplant in reality and referred for transplant. That doesn't mean every patient will get a transplant, but I really think that discussion is important. I prefer not to wait till it's too late to have that discussion, or that window of opportunity might close. So I think it sounds corny, but I do think that information is power, and making those decisions based on, knowledge is better than just out of fear. And transplant has to be personalized, and it's a really hard question to answer because it depends not just on the biology and the clinical characteristics, but it also depends on a lot of personal aspects of the patient, their support system, and their expectations. So it's a really difficult question to answer, I think, on this, in this forum, and it has to be personalized. But I for sure would explore a transplant, whether you do it or not, unless you're very advanced in age, which might be, someone who might be 75 or older. That may not be appropriate, but below 75, depending on other factors, I think it's always worth that discussion with the physician. Even if you think you may not do it, it's still worth discussing.
I can jump in as well. I mean, there's three principles. One is the Goldilocks principle, which is that, there is such a thing as you being too late or too early. Some people are going to do well for years and they really shouldn't be referred to a transplant. And to John's point, you don't want to wait till things are too late. The problem is that people come in, they're sick, they get on a JAK inhibitor, they feel well. And then we say to them, well, our risk scoring systems say to you, you're high risk and we should transplant you. And yes, there are enormous risks that come with that. And the patient understandably says, well, why should I take the risk? I feel great. And that's the problem, is that we have to pick the right time to go. And oftentimes the right time to go to the transplant is when things are going well, not when things are not going well. The second principle is one of my mentors, who's a transplanter here at MSK, is fond of saying transplant is always a choice, it's never a necessity. And I think that's true because, again, nobody can guarantee the transplant will work. And there's always the issue of, morbidity and mortality that can result of the transplant, right? I mean, in most places there's about a 15 to 20% risk of death from doing the transplant. So do you want to take that risk, right? And that's a difficult question. That's a philosophical question in many ways, not a medical question. So I think those are kind of, to me, two of the big things, big considerations when we think about a transplant. It's really the timing and is it the right thing for the individual?
Yeah, I could just fill in. I think that was fantastically stated. We surely like to do the transplant at the time of the best response. The question is, are we gonna lose the window? So that's what I would actually emphasize, that it's very individual decision and really matters not to lose the window. Once people fail the first JAK inhibitor, the outcome is not ideal in the second line setting. So therefore, very close monitoring and having the options ready at the time we notice that the JAK is failing is actually the key, at least to me.
I think all of those, thank you all for those answers. I would say to that individual that asked that question, if you are interested in learning more about transplant and what that process kind of looks like, I did host a webinar about a month ago with Dr. Jeannie Palmer from the Mayo Clinic. She's a transplanter that was also an MPN specialist. I think that one could be a really useful resource for you. So please feel free to check that one out. Next question that we're going to hop into here is treatment of primary versus secondary myelofibrosis. Are these treatment regimens pretty similar, or is one harder to treat than the other? Are there special considerations or certain classes of therapies that may only be available to either primary or secondary patients?
I can jump in. I mean, in general, we kind of think about the principles the same way, and that the treatments that we use are often the same for both, whether it's primary or secondary. The one thing that's interesting is that in patients who've had a prior ET or PV, oftentimes their counts will be higher, right? So sometimes PV patients who've transformed will still have a relatively high hemoglobin, or if they've had ET, they'll have a relatively high platelets, whereas primary MF, they may have lower blood counts. And so sometimes that will affect our choice of JAK inhibitor, but the basic treatment principles and tools are the same.
Great. I think that's a pretty good answer for that one. So we're going to go ahead and move on to the next one. And I think that this is one that will really interest all three of you, because it's about combination therapies and kind of what this next wave of treatment looks like. In particular, this question comes from Ned. He's asking about, what do you think about the potential of combination therapy using BET inhibitors with JAK inhibitors? But just even to broaden it a little bit more, I know I've had conversations with Dr. Mascarenhas about this, but just where is the field heading as far as these combination therapies go? Are there some clinical trials open that patients could look into? And then I guess tangential to that, are there clinical trials for low risk individuals as well? Or does someone have to be high risk to participate? I know that's kind of a lot there, but I'll let you guys kind of tackle that.
Well, let me try to jump in, and I think we can spread the wealth here between Raji and Lucia to answer this question. I'll just say two things. One is, I think very exciting to see the wave of combination therapies, because I do think it builds upon what's called preclinical modeling, testing these in human cells and in mice that are engineered to replicate the human disease, and demonstrating that we can get better responses. These better responses thus far have really been deeper spleen responses, which we keep saying appear to improve, associate with survival, but also improvement in symptomatology, improvement in anemia, improvement in biomarkers of disease like reduction in fibrosis, reduction in JAK2 mutation level or other mutations, reduction in cytokines, inflammatory mediators. So we're seeing a lot of data come in that would suggest that we're going along the right way. And the three of us have participated heavily in a number of different studies that have been highlighted recently, whether it's the pelabresib Manifest-2, the selinexor Sentry study, the nab-to-madeline PUISA study, or the imetelstat study, a number of different drugs that are even moving into combination, like nuvisertib, the PIM1 kinase inhibitor, that all build off the science and I think hint towards us moving in the right direction. The question that a patient may ask is, well, which one is right for me? That we don't have the answer for. Right now, we're just trying to explore and make sure that we can benefit without causing additional harm. But as we get more sophisticated, hopefully we'll be able to actually tailor these combinations appropriately based on, it might be mutation, it might be patient, characteristics, it might be things that might help us determine which one of these combinations may be best for what type of patient. I'm sure
Dr.
Lucia have something else to add there.
No,
Dr.
I
Rampal, there you
that
go.
that does cover it, right? I mean, I think we have a wealth of trials at the moment, and we're going to learn toxicities. We're going to learn whether or not there's any signal that these things work. But then the next question to me becomes, do certain drugs work better in certain patients, right? And for some things, the answer is going to be more clear, like the CALR directed therapies. But for other drugs, it's not going to be intuitive, and it's going to require us to do some careful science to figure the answer to that out.
Yeah, I agree with that. It's definitely very important for us to understand as a next step where to take these drugs and for what patient would benefit the most. And also we now have a couple other combination, including imetelstat or drugs that are actually looking beyond just the spleen and the symptoms. So that will also help us to define the endpoints, what really matters for these patients to make the responses more durable, more accurate, and then reaching kind of beyond what we are already doing with the single agents. Of course, it's important to improve upon the current responses that we've seen, because unfortunately, even in the frontline setting, the single agent JAK inhibitors do not provide more than about half of the patients and only responses in the spleen and symptoms as currently assessed. So that's why the other combinations with rational combinations and really signals for what patient would be benefiting from which drug the most would be probably on a front runner for this decade, where we're going to learn more. There are more in development than novel agents for JAK2 as well as calreticulin. So we hope that will establish some pattern as well as possibly could come in a combination. And I'm quite excited about the data they were shown in the Metalstat and other, where really we are going more behind just the improving the outcomes, but also improving the, like, okay, can we go deeper, suppress the inflammation as we have seen with the PIM kinase inhibitor, suppress the bone marrow, really see what's led to this and how could we possibly, if not revert it, then at least slow it down so the disease will not progress.
Okay. Right. And then we are getting a little short on time, so I'm going to skip to two questions that I think I've seen more widely asked. So if I did not answer your question, I apologize. We are just on a time limit here. So the first question, I think is a really good one. And this comes from Gail, and she's asking about PEG interferon versus hydroxyurea for pre-fibrotic myelofibrosis. Do you think one is better? Are there any studies out there that shows delaying or preventing of future progression, or where does the field even stand on using hydroxyurea or PEG interferon in pre-fibrotic myelofibrosis?
Well, I think that with pre-fibrotic myelofibrosis, a lot of our treatment principles really are extrapolated from essential thrombocythemia, in which case I think either of the drugs are reasonable depending on what you are trying to achieve. If it's somebody whose platelets are high, which is often how pre-fibrotic MF will manifest, it's reasonable to use either. There really isn't any firm data to tell us one is better than the other. But, if the prefibrotic MF is manifesting a little bit more like myelofibrosis, and maybe there's some, early anemia, or there's some degree of splenomegaly, there is, as we were talking about, data for interferon in early myelofibrosis. And so kind of drawing from early myelofibrosis in that particular case is a reasonable thing. So again, it always depends on what the clinical scenario is, but I wouldn't say that there's one drug that is better than the other in general for prefibrotic MF.
Right. And then this last one I think is just a really good general question for everyone to really know. But what are some things that a newly diagnosed patient should discuss with their oncologist? Um, they always get their blood work done for anemia, and they're being treated currently with retrostrit, but nothing else is discussed. What types of questions should they be asking to really get more out of their time when seeing their oncologist?
So maybe I'll try just weighing in. I mean, I think you have to gauge the oncologist you're dealing with in terms of their understanding of myelofibrosis, their time to go over, whether you are symptomatic, whether your spleen is big, what are their treatment goals in terms of what are they trying to achieve. If the patient's getting Retacrit, presumably that physician is trying to improve a hemoglobin, but you wouldn't want to miss a patient might who be symptomatic with like night sweats and weight loss and anorexia, and Retacrit may not be sufficient there. And again, the theme that we've been talking about is personalizing the approach. It has to be personalized to how the disease is affecting the patient, and that expectations of the patient need to meet the expectations of the physician, and vice versa. So having a discussion about what it is that is at play with that individual, what that physician is trying to address, and what numbers the patient should look at. One thing I would really recommend to patients is don't get obsessed with the numbers. It will drive you nuts, but there are certain numbers that probably matter, like the hemoglobin, the platelet count, the BLAST, BLASTs. Those are numbers that patients will often focus on. Meeting with the transplanter to make sure that that's been explored. Those are the things that I think would be important. And then, of course, I think the simplest thing is I would ask your hematologist, oncologist, how many patients with myelofibrosis do you treat? Because I think you'll find that in the community, and this is not a reflection of anyone in the community, it's just a reality, is that it's not that frequent. So it may pay to come and see, Dr. Rampal or Dr. Masarova or myself, even if it's one time, to get a consultation to understand where do you fit in this, and maybe help co-manage the disease.
Fun. All right. I think that's a really good answer, and I think a good place to end it here. The remaining questions that we have are a little bit more specific, so we'll go ahead and skip over those just because I don't quite think they are broad enough for our audience today. But thank you again to all of our speakers. We really do appreciate your time. This was a wonderful event and incredibly informative. So truly, thank you. Before we go, I want to highlight the Track My Disease feature on the HealthTree Care Hub. So once you've connected your medical records, you can use the Track My Disease feature to provide you with the ability to gain one-of-a-kind insight into your health information. This will encompass your lab results, genetic profiles, treatment histories, and really offer you an invaluable insight into your own medical journey. On the screen, I have the link to sign up for the HealthTree Care Hub, along with the email address for amazing patient navigators who are available to help you create your account and connect your records. We'll also be including some information about how to enroll in HealthTree Care Hub in our follow-up email, so be on the lookout for that. And then I want to highlight, we have a busy month in April. So I will be hosting 3 more webinars for our myelofibrosis community this month. On April 15th, we'll be talking about newly diagnosed with myelofibrosis, key things to know. This will be with Dr. Alexander Koltoff. On April 24th, we'll be discussing integrative oncology for myelofibrosis with Dr. Christina Godwin. And then on April 30th, this is going to be myeloproliferative neoplasms and cardiac health. And this is with Dr. Orly Leva, and they are actually a cardiologist who has published on MPNs and cardiac health in the past. So all of these are great events. You can register for them on HealthTree's website, and I hope to see you at one of them. And then finally, just thank you again to all of our speakers. Thank you again to everyone in the audience for joining today. And really helping us build a strong myelofibrosis community here. I've added my email to the slide. Please don't hesitate to reach out if you have any questions about HealthTree, any of our programs, you want to share your story with me, anything, I'm always available to any of you. But yeah, I really appreciate you all, and I hope you have a great rest of your day. Bye.